How to image the VSD? We have seen in before when we discussed the definitions of VSDs that it is the short axis view that's very important, because this view allows us to differentiate between the perimembranous VSD and the outlet defects, the supercristal and infracrystal outlet defect. We will use the apical 4-chamber and 5-chamber view, and particularly in muscular VSDs, which may be somewhere close to the apex. This may require atypical views and careful search for these VSD jets, and color Doppler is again very helpful to find these VSDs in rather unusual sites. Here are some examples. Short axis view, left ventricular outflow tract close to the aortic valve. We see in the 2D image that there is some aneurysmatic transformation here, and looking at the color, we see that there is still significant shunt here. When we only look at the 2D image, this could also be a spontaneously closed VSD, but by color we can easily confirm that there is at least some left to right shunt and only aneurysmatic transformation of this VSD, but not complete closure. This is a 4-chamber view with a typical example of a very large inlet ventricular septal defect, or AV canal type AVST. And by color Doppler, we can appreciate that there are only low velocities. There is no longer a jet, and this is not surprising. In this patient with this very large VSD, we have a non-restrictive VSD with equalization of pressures of left and right ventricle, and therefore we can no longer expect higher velocities. Here again, a trabecular or muscular VSD seen in the short axis view on the left-hand side and in an oblique 4-chamber view on the right-hand side. Again, a patient with a perimembranous ventricular septal defect. We see here a 5-chamber view, and again the aneurysm formation can be nicely appreciated in this image here. And as I said before, this can either end up in a complete closure by this tissue growing from the tricuspid valve over the defect, or at least a partial closure with aneurysmatic transformation of this ventricular septal defect. Now, this is a patient where we have both inlet ventricular septal defect and primum ASD, so this is a complete atrioventricular septal defect or complete AV canal, and we see the common AV valve here. So this is a quite different, more complex malformation, and now the complete form of an atrioventricular septal defect. This is an example of a patient where we have anatomically, again, actually complete AV canal, because we see there's also an inlet ventricular septal defect. But again, we have tissue growing here over the ventricular septal defect, and we have complete closure of this ventricular septal defect. So we end up hemodynamically with a primum ASD or partial AVSD shunt only on the atrial level, and in this patient again some degree of mitral regurgitation and tricuspid regurgitation with several complex jets. This is a small ventricular septal defect which may be difficult to find, and this is a situation where we see again how important auscultation is. So as soon as we hear a ventricular septal defect, we should not give up to find it by transthoracic echo, and if we look very carefully, we will even find these peculiarly located muscular ventricular septal defects. A very small defect, but can nevertheless cause a very prominent ventricular, very prominent systolic murmur. What are the associated lesions in membranous lesions? The already mentioned aneurysms, subaortic stenosis, double-chambered right ventricle, which is a muscular obstruction of the right ventricle. I have also mentioned for the subpulmonary or supracrystal outlet VSDs the problem of aortic valve prolapse. And of course, primum ASD and cleft mitral valve can be combined with an inlet VSD and is then one variant of a complete AVSD, as we have seen in some examples.